The first is to measure the mess. Life is a mess, and medicine is a mess. Healthcare is a mess. That's the reality, right? We like to measure it, we like to validate it, we like to kind of test it in clinical environments, in randomized controlled trials. They're lovely things, but they're artificial for a reason, because life is too messy. And I think now, importantly, we are at the opportunity where we can start to move into the mess and not have to, in essence, replicate a synthetic environment, but actually measure the reality. Propeller Health is one of my favorite examples of measuring the mess in a kind of bottom-up world. This is a very clever company out of Madison, Wisconsin. They started as being called Asmopolis. And Asmopolis was, what they figured out is that they could attach sensors to people's asthma inhalers, and out of that create a map and a data set out of what are people actually experiencing and where. The second idea is to design for the end user, right? So this is a core principle of user experience. It's been around for 20, 30 years, but it's just coming to healthcare. And I think the way we need to think about this is, who is the end user? And it's a big shift that is still taking place in healthcare. Too often, the end user has been the person with a paycheck or with a checkbook, the person paying the bill, and not the patient or the person. Dollars to donuts, anybody going to a patient portal probably has fear, uncertainty, or doubt in mind, right? So you don't really grapple with your healthcare until you have to, and then you come here and, oh boy, I feel so much better. That is starting to change. Some of you in this room are starting to change it. We are all starting to change it by thinking about what the end user actually could use. So the third thing I want to talk about is forking the code. Does anybody know what I mean by this? Thank you. So in software, open source software in particular, there is really a dramatic shift in software over the last 15 years towards open source software, where you make code, you develop a piece of software, and you make it available to other people, right? So it's free. Sometimes there's a slight charge, but largely it's free. And places like GitHub and SourceForge have emerged to be hubs where people can share their code. And what's remarkable is Facebook is sharing their code, Google is sharing their code. People who solve problems internally, companies that solve major problems internally, then share that code freely for other companies to use and adopt and adapt. And when they adapt it, when they take that code and use it for their own purposes, it's called forking the code, right? So they fork it, take it in a different direction to serve their own purposes and needs. Too often, we're stuck in pilot projects and in trials and in, yes, the research is published there, but we have to validate it again over here, and that's going to take a year or 2 years or 3 years, and we never get around to taking what has worked elsewhere and putting it into effect. An example of this, a great example, is Propeller Health. They have taken the diabetes prevention program, which is a validated piece of massive public research, and they turned it into largely a software program. They turned it into an algorithm by which people could enter a program that's largely app-based, but it also has some human contact when necessary, and it leads people through basically an obesity and diabetes prevention program, and it works because they took a kind of very high-touch, validated piece of academic research and turned it into software. And that is an effective way to scale ideas. It's an effective way to fork code. This is the Southeast Health Center in San Francisco, not far from where those buses are parked at the end of the shift. And this is a great example of a kind of all these three principles coming to roost. The head of the Southeast Health Center is a fellow named Dr. Keith Seidel, and he went to an Apple store and was inspired by how they helped people at the Apple store. And he had a clinic that had, was miles, leagues away from an Apple store. They had a backlog. It took I think, 99 days to get the third visit, which is a standard arbiter of efficiency of care. And they had people just waiting and frustrated, and they felt understaffed, under-resourced. It was a classic disadvantaged clinic in a disadvantaged neighborhood. He went to that Apple store and he was inspired, and he flipped it around. He took the nurses from behind the waiting room and he put them in the front. They started to meet the patients as they came in. He took the appointment book and he changed it to 50% appointments to or from 100% appointments to 50% appointments, 50% walk-in. So people could be moved rapidly in, if they just showed up, they could be moved and actually get an appointment. After a few months of this, they got the point of time from when somebody walked in the clinic to being in an actual examination room to 4 minutes. It is a remarkable testament to the power of thinking differently, so to speak, and the power of not accepting the status quo.